Hello and welcome everyone to our latest general review on the reverse AKI trial. It is a pilot randomized controlled feasibility trial. Current management of AKI remains supportive and it includes optimization of the hemodynamics, the fluid status, avoidance of nephrotoxin, and severe cases patients need renal replacement therapy. Fluid therapy is the traditional cornerstone of AKI prevention and treatment. Patients with AKI are also especially prone to develop fluid overloads. Now, the objective of this study was to check the feasibility of comparing a restrictive fluid management regimen to the usual care among ICU care patients with AKI to study the feasibility of such intervention in terms of the fluid balance separation, the safety of doing restrictive fluid therapy, and lastly, the compliance. Now, this was an investigator initiated, multi centered, unblinded, randomized control, parallel pilot feasibility study. Now, it was done in 5 ICUs of Europe and 2 Australian ICUs. And the inclusion criteria were they included patients who were 18 years or more who had to be in the ICU for at least 12 hours. The initial resuscitation of period of 12 hours has to be there and it has to be done in the ICU, but it should not be more than 72 hours. And the patient must have some AKI. This was mainly the KDIGO definition of creatinine and urine output. And the patients were judged by treating clinician to not be intravascularly hypovolemic. If the clinician after the 12 hours of resuscitation still feels that the patient is having some sort of hypovolemia, then the patient was not included in the trial. Now, lastly, the patient has to be in the ICU for at least 48 hours after randomization to be included. Now, the exclusions were active bleeding, which necessitated transfusions, patients who do need some sort of maintenance fluid, like in diabetic ketoacidosis, non ketotic coma, burn patients, or patient needs RRT for some other cause like intoxications, or the RRT has been initiated in the previous 6 hours, or the patient is already on RRT. There is severe hyponatremia, hypernatremia, presence of clinical suspicion of parenchymal AKI like glomerulonephritis, acute interstitial nephritis, need for ECMO, MARS, pregnant lactating women, patients who will not be receiving full active treatment, or in patients in whom the baseline creatinine is unavailable. And lastly, the patients who do not give consent. So the intervention. Now, the trial intervention, that is the restricted fluid management, consisted of a bundle of treatment recommendations for the clinicians to follow during this trial. Now, the overall aim for the clinician was to achieve a negative fluid balance on the days following the randomization. For this, restricting the total fluid intake only to the medications and nutritional fluids, that is enteral or parenteral, or blood products. There should be no maintenance intravenous fluid unless the patient is not on enteral feeds and is having some contraindication to parenteral feeds. Fluid bolus therapy should be given as clinically deemed necessary, matching fluid output with restricted use of diuretics to fluid intake whenever possible to achieve a preferably negative cumulative fluid balance. And lastly, if the patient's fluid balance is not being met, that is, the patient is not getting negative, there is a provision to do RRT. But this was not something which was very strongly recommended. It was told to avoid RRT as much as possible. It is only if the clinician is strongly suspecting that the benefit of giving a RRT would be very high, only then the clinician was recommended to go for RRT for fluid management. Now, the outcome was primary was the cumulative fluid balance at 72 hours after randomization, which was adjusted for the stratification variables. Now, if you look at the statistical analysis, the sample size calculation was based on the fact that they were estimating a difference of 1200 milliliters in the primary outcome, and with a two-sided alpha of 0.05 and a power exceeding 80%, they needed 50 in each arm. This is based on the Finaki study. It was estimated that the cumulative fluid balance at 72 hours would be 2700 ml in the usual group and 1500 in the restricted group, with a standard deviation of around 2000. Fluid balance was calculated by subtracting total fluid output, that is urine output, loss from drains, loss from GI tract, and urinary ultrafiltration, with total fluid intake, that is intravenous and oral. The most important is the insensible loss was not considered in this particular calculation. The intervention period was 7 days, that is from the point of randomization till 7 days, or until the patients get discharged from the ICU. So total 997 patients were assessed. Out of this, 895 were excluded. So a lot of patients got excluded. 227 were judged to be intravascularly hypovolemic by the clinician at 12 hours, and 278 were not likely to remain in the ICU at 48 hours after randomization. So a lot of patients, almost 50%, got excluded because of these reasons. So ultimately, they included 102 patients, 50 in each group, and they were analyzed. So if you look at the patient characteristics, it was roughly similar between the two groups, both in terms of age, sex, comorbidities, type of admission, and all. But one thing that we need to look at is that there are a lot of surgical patients. Almost 40 to 45% of the patients were from surgical group. Sepsis is 55%, septic shock is 10%. This is a fluid balance in restricted fluid management group versus usual group. In terms, this is the intake, this is the output, and this is the balance. So as we can see, there is a consistently negative balance in the restricted fluid management group compared to the usual care group. So overall, what were they expecting to find in the restricted fluid management group, they could achieve in most of the cases. So if you look in terms of the primary outcome, there was a significant difference in the cumulative fluid balance at 72 hours, which was statistically significant, and the duration of AKI was also less in the restricted group. Apart from that, the number of patients receiving RRT was also significantly higher in the usual care group, which was 13% versus 30%. Cumulative fluid balance was significantly different at 24 hours as well, and the cumulative fluid balance at day 7 was also statistically significant. But the use of furosemide was similar in both the groups. Now, in the exploratory outcomes, in the patient related outcomes, that is days alive free of mechanical ventilation, days alive free of vasopressors, ICU treatment, and RRT, were more or less similar. And the mortality was also roughly similar, though it was 7% higher in the usual care group. If we look in terms of the adverse effects, because we are expecting some adverse effects of doing this kind of a restrictive fluid management, there was no such adverse effects, both in terms of cardiac problems as well as rim ischemias or electrolyte abnormalities. Now, regarding the use of diuretics, it also did not have any significant impact on the outcomes. Regarding protocol violations, it is important to note that there was a lot of protocol violation in terms of the maintenance fluid. This is mainly because it was a multicentric trial. There were a lot of local practice variations. So 18% of the patients did receive maintenance fluid therapy, even though they were into the restricted fluid management group. So if we compare the data of this study in terms of previous studies, that is the FACT trial, which was conducted in 2000 to 2005. This was mainly done in ARDS patients, which found no difference in terms of mortality at day 60. However, it did find a shorter duration of mechanical ventilation and a trend towards less RRT in the conservative fluid arm. Now, the sub-analysis of the patients with AKI found an important association with high cumulative fluid balance and mortality. The cumulative fluid balance on day 3 was about 1500 ml in the conservative arm and about 5000 ml in the liberal arm. Now, this, if you compare in terms with the result of this trial, then there was a significantly lesser fluid being given currently compared to what was being given before. Now, the limitations of the study, it was unblinded because the intervention was not something which could be hidden. The exact fluid balance was not calculated because the insensible loss was not, it may not be of importance in usual patient, but in surgical patients or in patients who have a large wound, this could be of significance. The next is protocol violation in terms of excess maintenance fluid, as we have already discussed, because of local practice variations. Next is the patients with treatment limitations. Although there was a lot of patients were included, we also had a large exclusion criteria. Almost 80% of the patients who got admitted to the ICU were excluded. So we are excluding a large chunk of patients. So this study isn't exactly reflective of the population that we get in our ICUs. Lastly, a quarter of the excluded patients were ineligible because they were still considered to be intravascularly hypovolemic in spite of being resuscitated for 12 hours inside the ICU. This is an important group of patients, and this is a group of patients in which we do really want to know whether we can do a restrictive fluid management or not. Excluding this patient is one of the major limitations, and it should be addressed in the future trials. Now, if we look at what is the conclusion of this study, then the use of the restricted fluid management was feasible. It resulted in fewer adverse effects, and it had a significant separation in terms of fluid balance. Even in terms of patient outcomes, it did show some benefit in terms of AKI RRT requirements, but we do need larger studies to establish these patient-centric outcomes. So overall, this has been a positive study which shows the feasibility of doing restrictive fluid management and the fact that it is not something which is going to cause any severe adverse effects. However, doing it as early as 12 hours is something which need to be evaluated more in the future trials. Thank you for your patience, and check our website for the information.